Welcome. Good evening, everyone, and welcome to this webinar hosted by the University of Melbourne Department of Physio. I'm Associate Professor Jenny McGinley. I'm the head of the department, and I'm delighted to welcome you here this evening. I'd like to first start by acknowledging the first and continuing custodians of Melbourne, the Wurundjeri people of the Greater Kulin Nation. I offer my respects to their elders, past and present, and to all Aboriginal and Torres Strait Islander people who might be with us tonight. Today, our physiotherapy community join this webinar from across Melbourne, across Victoria, Australia, and indeed from different parts of the world. And I'd like to welcome you all. This evening, we're exploring the topic physiotherapy, lessons from a pandemic. 2020 has been a year forever changed by the pandemic, a year of significant challenge for us all, no matter what country you live in, no matter what industry you work in or what you might study. In the face of adversity, here our alumni and staff have found opportunities to continue to provide excellent care and to contribute to our community in need during the pandemic. Before I start, I'd like to thank our generous speakers for giving up their time this evening to speak with you tonight and to share their learning. We really appreciate their time, their insights, and sharing their experience with our audience tonight. I am extremely proud of their efforts. Without further ado, I'd like to now introduce you to our facilitator for this evening, Dr. Natalie Fenny. Nat is a postdoc researcher with a keen interest in physical activity after neurological injury. She's also a lecturer here in the Department of Physio. Thank you, Nat.
Thanks so much, Jenny, and good evening, everyone. So Jenny's already introduced me, so I won't do that again, but I'd very much like to thank our panel for joining us this evening. So now I'd like to introduce our panel of fantastic speakers. So please welcome Sarah Miller, Professor Rana Hinman, Professor Kim Burnell, Professor Alicia Spittle, and Associate Professor Kathy Sade. So firstly, let's welcome Sarah. So Sarah is one of our DPT alumni, and she is currently a senior physio working at the Alfred, but she's recently moved back from London, where she was a team leader and senior ICU physio at King's College. So yes, Sarah, if you would like to share your experiences with us.
All right, so thank you very much for the intro, Nat and Jenny, and thank you for having me and asking me to share my COVID-19 lessons. To kick off tonight's panel, I'll share my experience in London and what I have seen since being home in our second wave. Firstly, as you know, it was a very different work environment to what we have seen here in Australia. The figures on this slide from the NHS Trust that I worked at speak for themselves. My work in the recovery ICU was dark and cramped. It felt like a modern day war. But a lot of the work we did at King's was great, some of which included a wellbeing centre for staff and great patient care that we delivered. We made up over a third of the patients in this study on the slide, which is one of the few trials that we had to have to guide COVID-19 care. So what did my day-to-day look like? As mentioned, most of my time was spent in our recovery ICU, which was usually a theatre. But during the expansion of our ICU services, it became a unit that took us to 300% capacity. The three elements of my role are listed on this slide. We had a lot of nurses redeployed in ICU. Many patients didn't need or weren't ready for physio, so we shifted our service provision to transdisciplinary approach, where we could help the nurses who had been redeployed complete their tasks, like taking OBS, changing equipment, assisting with turns, and associated manual handling, particularly as many patients had high BMIs and later reported new musculoskeletal injuries. This also allowed extra support to complete personal and oral patient care. While we were helping our nursing peers, we completed a modified physio assessment to determine if there was any indication for further intervention. If needed, we completed more formal physio input, including advice on prone positioning, ventilation weaning, airway clearance, which was particularly common for patients with higher BMIs, and started early mobilisation, which was often limited by delirium and patient's mood. My afternoons were very dynamic, depending on what was needed on that particular day. I would go between afternoon treatments, back in ICU, supporting staff on the wards, to project work, which we used to solve problems of the issues we were facing during this unknown time. Before I talk to these projects that help us provide strong clinical outcomes, both for our patients and our staff, I would like to share this video, which was taken in April, of my first COVID-19 survivor being reunited with his family. That help us deliver care for him and our other COVID-19 patients are listed on this slide. First was the work we did across the hospital on prone positioning, including our prone team. We designed a medical, nursing and physio-led care pathway on prone positioning to help manage the demand from HDU to ICU. We had a number of cases that were effective in preventing ICU admission, and this collaborative piece also helped patient safety for timely transfer to ICU, as well as providing great partnership opportunity with our medical team. We noticed that on the ward, prone positioning helped to inform ICU care. Those that didn't respond on the ward had limited benefit in ICU. We developed consumer information in response to our patients requesting it, but also to minimise infection control risks by encouraging self-proning and relieving staff stress, given respiratory care was being completed by many physios whom don't usually do so. Second, I will speak to our bread and butter, our patients and their rehab journey. As already mentioned, early mobilisation in ICU was often limited by delirium and/or mood. We made 2 small tweaks to what was considered normal practice at King's. We completed consistent use of the CAM ICU outcome measure and iPads during therapy to involve family, both in ICU and on the wards, both of which improved therapy outcomes through enabling us to better engage with our patients. Through audits and clinical observation, there seemed to be a very specific target group in ICU, that of 50 and 60-year-old males, often with high BMIs and/or diabetes, a lot of which were still working and had young families, which meant for the transition of our care from ICU to the ward, we looked at how we could optimise exercise dosage using the PFIT outcome measure, which was not readily used at King's before COVID. We also considered other outcome measures to incorporate high-level balance in our sessions, as this was more appropriate for our younger cohort. Lastly, the consumer pamphlet that I mentioned also helped to provide patients with discharge information, as there was no formal discharge pathway for many of these patients who were going home with an unknown virus and uncertainty of what lay ahead. So since being home via the infamous Stanford Plaza, what did I learn? I'm incredibly excited to see the outcome of emerging work on prone positioning, as I think it will help inform and better manage ARD's clinical practice in the future. I've always been very passionate about the role of transdisciplinary leadership, given a lot of my training has been as a care coordinator. And now through spending time on the SCOVID ward at the Alfred, I have seen some brilliant care models using allied health leadership, which I believe will be very helpful to solve the complexity that comes with our ageing and chronic population. And third, I have recently started with the Department of Health and Human Services. We have already started planning for our next pandemic and positive changes that lie ahead. We now have many key lessons that will inform the success within our hospitals, government, and hopefully globally. To finish, there are a few themes that I think play a large role in our future service delivery as physios. How we adapt to new ways of working, what this means for the future of chronic respiratory disease, long-term neurological conditions, and the emerging frailty risk from physical and emotional isolation for our oldies, as well as how we deliver integrated care moving forwards. Physio as a profession may pick up early signs of cancer or neurology in private practice clinics, and in the broader health landscape, our exposed gaps with mental health and domestic violence speaks volumes to the impact we can make as physios to Australian healthcare. Thank you for listening.
Thanks so much, Sarah. That was a really, really interesting presentation, and great to hear about your experiences in the UK. So now I'd like to welcome Professor Rana Hinman. Rana is the Deputy Director of our Centre for Health, Exercise and Sports Medicine. And Rana's going to talk about the PEAK training program. Thanks, Rana.
Thanks, Nat. As Nat said, I'm going to talk briefly about the PEAK training program, which is a program that we released early on in the first wave back at the start of April. We had been ahead of the pandemic, started last year, a non-inferiority trial comparing video conferencing to face-to-face care by physiotherapists for people with knee osteoarthritis. This trial was already underway, and as part of the trial, we had developed an online training program to teach the PEAK physios who were involved in the trial about the interventions that we wanted them to deliver as part of the trial, and importantly about how to deliver care via telehealth, because lots of physios were unfamiliar with telehealth at the time. Then, of course, COVID hit. And as everybody's aware, a lot of physio services and allied health services, and indeed lots of medical care out in the community, switched across to telehealth. And word got out that we had had some training modules, and we got quite a few requests from a range of physios and some who had been involved in the trial to release the training program to help physios who were trying to really rapidly switch across to delivering telehealth with not really any idea how to do it or any skills or training in how to do that. The program it's very focused on knee osteoarthritis, and it's a very structured program that assists physios to deliver 5 one-to-one physiotherapy consultations. And the training program facilitates people to deliver it either face-to-face or using telehealth video conferencing. And in the training module, and indeed in the PEAK trial, we use Zoom. So there's lots of material in there about that. The intervention focuses on patient education, on how to deliver an effective lower limb strengthening exercise program, an individualised physical activity plan, and also comes with a series of downloadable patient information booklets, as well as a website of exercise videos that the physio can use via the screen sharing feature during video consultations to help teach exercises. These are just a few images from where the program is hosted, which is on the University of Melbourne LMS site. 3 key modules. The first one being around osteoarthritis and the core recommended treatments. We have lots of little video clips in there to break up the text and a range of different teaching strategies. A module about telehealth and with a focus on video consultations, including how to use Zoom and the various features of that. And then the final module is the very structured PEAK program, where it takes physios through the different treatment ingredients structured into 5 consultations and supplemented by a range of video clips showing how to deliver this over video conferencing using Zoom. We released the program free of charge on the 1st of April, and you can see here the little timeline across the top sort of shows the flow of people. Once they log a user request in the system, they then have to activate their LMS account. And we quickly set up a pre-training survey and a post-training survey to do immediately pre and post-training. And right now we're in a phase where we're actually implementing a survey to users 4 months after completing training. So you can see that we've had over 6,000 user requests, of which almost 2,500 have gone on to do the pre-training survey, and over 1,200 have completed that. This data is a few weeks old now. Amazingly, we've had users from 97 countries sign up. You can see the top 5 countries there, so really from all over the world. And word of mouth really did push this out globally, where you can see work colleagues, social media, the professional organisations across the globe were really keen to disseminate this program as well for us. You can see from this data here that the vast majority of our users at the start of training were not currently offering video conferencing and had limited skills in that. And in fact, we asked our users to rate their confidence in using video conferencing pre-training. And you can see here from this slide that there's a really, really wide variety of confidence level there, but really only 22% scored out of 8 or more out of 10 pre-training. Pleasingly, post-training, we can see a real shift in confidence levels for using video conferencing, with 73% or more of users scoring 8 or more out of 10 post-training. And when we immediately surveyed our users as to how useful they found the peak training program, again, we found that 80% of users scored 8 or above with respect to usefulness of the program. Now, 4 months on, we've just started surveying our users because we're really keen to see in what way did this program that we really did release quickly at scale, did it influence people's clinical practice or educational practice? And whilst this data is only just coming in now with only just around 120 users or so, we can see that 53% said that the training program influenced their practice to a moderate extent, 12% to a large extent, and 34% to a minor extent, which was really pleasing. And I think this slide really nicely shows the really different ways that users have implemented what they've learnt. The resource booklets in the way of the information booklets for the patients, as well as some downloadable clinician resources that we had there, were really popular. But you can see that users also used what they learned to inform their current face-to-face consultations, to inform their telehealth consultations and improve their telehealth skills. Lots of people used the video library. Some people went on to adapt and create their own resources from the information and what they'd learned. And a number have actually gone on to translate resources as well. Pleasingly, a quick search of the internet now shows how various physios out there in Australia have used the training program and now advertising on their websites, on their blogs, using the peak program for marketing, including on social media. We've currently got translations either completed or underway by a whole range of clinical champions out there across the globe in Greek, Spanish, Chinese, and the latest ones are Romanian, Hungarian, and Italian is just about to get going as well. And really pleasingly, we've seen the program incorporated into curricula, including here at University of Melbourne into our DPT program, but parts of it's also been uptaken at the University of Queensland in their master's programs, and various aspects of our video conferencing, including our video clips, have made it into the various bachelor degrees over in New Zealand as well. And these are just some of the ones that we know about. So it's been really, really pleasing to see the uptake. And just to finish off, I'd really like to acknowledge the enormous efforts of Alex Kimp and Penny Campbell in our research team and the funding that we have from NHMRC to support the PEAK trial. And if anyone's after any further info, you may either email me or you can also look up our trial protocol for the PEAK protocol, the PEAK trial that's been published earlier this year. So thank you very much.
Thanks, Rana. What an amazing uptake of the program. Congratulations. That's fantastic. So now I'd like to welcome Professor Kim Burnell. Kim is our Director of CHESM, our Centre for Health, Exercise and Sports Medicine, and Kim's going to present on the advocacy work that she's done with the APA during the pandemic. Thanks, Kim.
Thanks very much and welcome everybody. I'm just going to briefly talk about 3 different surveys that we've been doing with different stakeholders to look at telehealth, the experiences of allied health clinicians, including physios and patients during the pandemic. And just like to acknowledge a whole range of people there, including Rana and others from the APA and UQ and Flinders University as well. And I think it was driven because obviously one of the barriers to telehealth before COVID was that there was lack of funding available. And then COVID came along, and really probably, I suppose, one silver lining of COVID was that it really accelerated the uptake and funding for telehealth. But these funding sources were brought in for sort of temporary, and so a lot of the stakeholders were interested in ensuring that the funding for telehealth continued after the pandemic. But in order to do that, you need some data to support that. So the three different surveys that we've been doing, one is, they're all online, and one was with the Australian Physiotherapy Association as the partner and the Physiotherapy Research Foundation. And that was looking at video conferencing only. We didn't do telephone at this stage, and we did this very early on, probably would have included telephone now in retrospect, but it was surveying the physiotherapists and the patients, and this is numbers that are a little bit out of date at this stage. I think we've got over now 400 patients and over 200 physiotherapists. We also working with the Allied Health Professions Australia and with a number of different disciplines there as well, and you can see the different disciplines that we've been involved as well in surveying both the patients and the clinicians in those different disciplines. And this time we're looking at both video conferencing and telephone as well. And then the third survey, again, I'm not going to be presenting any results of this one, but just to mention that we've had a very good study that's been supported by the Melbourne Disability Institute at the University of Melbourne, working with the National Disability Insurance Agency to do a survey of recipients of the NDIS or their carers about their experiences with receiving different allied health services during the pandemic, and about their experience with changes that the NDIS implemented to cope with the pandemic and the lack of face-to-face. And so again, we've surveyed patients who, not patients, but recipients who received care from a number of different allied health clinicians. So we'll be able to have a really big pool of data across a range of sources. So just briefly going back to the survey that we've been doing with the Australian Physiotherapy Association, as I said, it's still ongoing, won't be finished until November. But you can see that most of the physiotherapists were in private practice, and that probably reflected the fact that our ethics really only covered community. It didn't cover hospital settings, even though obviously a lot of physios in hospital settings were also delivering telehealth services. Again, you can see that most of the physiotherapists had, as Rana mentioned, very little prior training in telehealth delivery. You can see 86% of them had had no prior training. And what they were offering was generally one-on-one consultations, but there are also a fair proportion were also offering group classes via video conferencing. And the physiotherapists will complete their survey about their experiences in November. A little bit about the patients that completed the survey. A lot of them were women, which is what we tend to find filling in surveys. And most of them were from Victoria. Again, probably reflects the lockdown and the second wave we've had down here. Most of the patients were from a major city, aged around 51 years. And again, most of them had a chronic condition that was more than 12 months in duration. Again, just this short slide just really shows that patients were seeking treatment for a whole range of different reasons, different conditions, whether it be impaired function, pain, bladder, bowel, breathlessness and so forth. So they were seeing their therapists for a whole range of different reasons. Now this looks a little bit busy. I've put all of the different, I've combined the results from the two surveys that the Allied Health Professions Australia plus the APA one, but really you might just be interested in the left, which is the physio here. And this basically shows you the percentage of patients that answered in the positive or negative for the different questions that we asked them. So for this one, it was about their expectations of treatment via video conferencing. You know, what were they thinking, and did it meet or greatly exceed their expectations? And you can see that around 60% of physiotherapy patients, the treatment either somewhat exceeded or greatly exceeded their expectations, and only a very small proportion felt that it was less than what they had expected. How safe did they feel during the consultation via video conferencing? And again, you can see physio there on the left. Majority of people felt safe, and that seems to be relatively consistent across the different disciplines, except for some of the other disciplines that you might see there, OT and certainly podiatry, although the numbers are very small. But very pleasingly, no one felt unsafe in the physiotherapy treatments that they had had compared with some of the other different disciplines. How satisfied were you with care via video conferencing? And again, you can see for physios, just over 70% were very extremely satisfied with the care that they had received. And then if you add in somewhat or moderately satisfied, you can see around 98% were either somewhat moderately or very extremely satisfied with their care, and only a very small proportion there up the top were dissatisfied. And you can see if you look at some of the other different disciplines, you know, there seems to be a little bit more dissatisfaction, although again the numbers are a bit smaller, but we certainly have low dissatisfaction and a lot of high dissatisfaction with our care. This is what the stakeholders were very interested in. A lot of them were thinking, so for example, the private health insurers and others were thinking that this was just going to open the floodgates and everybody would be wanting to use telehealth and it would be increasing their costs. But in actual fact, what you can see from this, how likely would you be to use telehealth or video conferencing physiotherapy consults after COVID? You can see that about 20% would be very likely, somewhat moderately likely, and very or somewhat unlikely. So about 30% or so would be very unlikely to use it after the pandemic. But you can see that a proportion really would be likely to use it. And so I think what we were sort of saying to the stakeholders and the health insurers is that not everyone's going to want to have, it's not going to replace face-to-face care, but certainly what we need to have is choice so that patients can choose what medium suits them best. We also looked at whether there are any difference in responses for metro versus regional rural patients, physiotherapy patients, and there didn't seem to be any differences in terms of their satisfaction or their effectiveness, ratings of effectiveness, so equally effective and satisfied across those. And so the results of these 3 different surveys are being used and will continue to be used by the APA and the other organisations to really help lobby for continued funding for telehealth delivery of physiotherapy and other allied health care. And the NDIS have also been using the results from the survey to inform them going forward as to whether they will continue with offering those services, which I think it's looking highly likely that they will fund telehealth services going forward for the recipients of the NDIS, which is great. And thank you.
Great. Thank you so much, Kim. That was a really interesting presentation. Now it's time to welcome Professor Alicia Spittle. Alicia will be presenting on setting up telehealth models of care for paediatrics. Thanks so much, Alicia.
Thanks, Natalie, and it's a great pleasure to be able to present to you tonight. I'm going to present on a few different topics, and obviously we've only got a short presentation, so I'm just going to touch on these, but it shows you some of the different things that we've been able to do in response to the pandemic. So the first one I'm going to talk about is an online education program that we developed for clinicians in response to early detection and intervention of developmental disabilities. And part of this actually was inspired from the PEAK program that Rana spoke about earlier. So just to put in context for some of you who aren't familiar with paediatrics, then cerebral palsy affects 1 in 500 births and affects 17 million people worldwide. And as many of you will know, children are not thought to be as affected by COVID, but it doesn't mean that it's not important that we think about our services for children. And one of the concerns that we had is that children who have, or infants who are at risk of cerebral palsy might not be detected early because they're not actually getting follow-up services. So traditionally there has been a wait and see approach with cerebral palsy, in that we wait until a child is quite delayed in their development before cerebral palsy is investigated. And this has resulted in a very late diagnosis of cerebral palsy at around 19 months of age. And if we look at development, we know, particularly for motor development, that the first 2 years of life are the most important in terms of neuroplasticity. So if we're waiting for 19 months before we even diagnose a baby, they're missing out on a prime opportunity for early intervention. So if, a few years ago now, back in 2017, we got together with a group of experts in many different areas, including consumers, and put together these guidelines which are published in JAMA Pediatrics on how we should provide early detection and then intervention for infants with cerebral palsy. And part of this was to provide infants who are at high risk of cerebral palsy with very close monitoring very early in development. So this is an infographic that we put together for clinicians based upon that paper, which summarises all the different key points. And the first being that if the child has a motor dysfunction, which we assess with assessment tools in the first 3 months of life, we should then combine it with neuroimaging and their clinical history to make an early diagnosis. But of course, with COVID, what happened is we stopped seeing these babies face to face, and many of these infants weren't receiving any follow-up at all. And no one really knew what we should do, because obviously we were all responding to the pandemic in different ways. And one of the I guess there was a big focus on the acute, but then we really needed to think about what happens to this whole cohort of children who might not get that early developmental follow-up. So as I said, we were inspired by some of the work that Rana and Kim and her team at Chesham were doing, and thought about, well, maybe we could develop a similar online program which could help clinicians related to early detection of infants with developmental disabilities, in particular cerebral palsy. And I wanted to acknowledge Kate Rawnsley, who's a PhD student who's put a lot of work into this program. So we were lucky to receive a small amount of funding from the Melbourne Disability Institute to put together a similar program, as I said, inspired by PEAK, but very much targeted to a different audience. So again, we had several modules, and we had one module on understanding telehealth based upon the work that they had done, but adapted it to pediatrics, another module on early detection, one on early intervention, and then one on changing people's practice, because that's and identifying barriers to change and behaviour change. Because even though we know that there's all these things we need to do, what can we do to actually change our practice? Within the module, again, we had different videos, different ways for people to think, how can they do these things via telehealth when we're used to getting our hands on our patients, and thinking about how we need to adapt our environment to assess a baby, because unlike an adult, we can't necessarily put the person in front of the screen and ask them what to do. We need to think about, where do we put the laptop on the ground so we can see the infant move without them destroying the laptop at the same time. So we put together some handouts as well to help families prepare for their telehealth appointment, and these were available on in our Teddy program, but also we made them available online through many different areas, because we wanted them to be translated into practice. And we've also had these translated into Arabic and Chinese, and they've been used worldwide, and we're just thrilled with the amount of the spread of these handouts. In terms of our Teddy training program, we haven't had quite the diversity as PEAK, but we've had 455 participants since we launched it in the middle of the year, from 28 countries. Most of them have been physios, but we've also had doctors, speech pathologists and OTs, and of course others. And in terms of the settings, we've had a real variety as well. So about a quarter in tertiary hospitals, some in regionals, some in community health and early intervention. Interestingly, similar to some of the data that we've already seen, the majority had never used telehealth prior to COVID. So we're really seeing a big practice change. And we've been lucky to use some similar rating scales, similar to what Rana has presented, and I won't present those for you tonight, but we're again seeing really positive results from the training program. And if anyone's interested in it, they can email me about that. So the next thing I wanted to talk to you about is a randomised controlled trial of telehealth to improve developmental outcomes for infants born preterm. And this is called TEDI-PREM. And we were fortunate to receive funding from the Medical Research Future Fund to do this intervention. And we actually submitted our grant prior to COVID, but I think the fact that there's such acknowledgement now of the importance of telehealth, it really helped us potentially to get the project funded. And what it is a study, it's a multi-centre study in Victoria, and it's a randomised controlled trial comparing our TEDI-PREM approach with usual care in 466 babies who were born very preterm. And our aim is to improve their motor outcome at 2 years of age. We're also going to do a number of assessments throughout their first 2 years of life to see what their therapy services usage is. And at 12 and 24 months, we're going to do a number of different assessments, not only of the child's development, but also of the parents' mental health and their child's health and quality of life as well. In terms of the actual intervention, it has 3 phases. The first phase actually starts face-to-face in the NICU, and we have 4 sessions focusing on parental wellbeing and also the infant's development and play interaction. And then over the first 6 months of life, we then move to telehealth. And one of the good parts about this is that we can then actually service babies through all over Victoria, rather than people having to come back to our hospital and travel a long way, and often the services just aren't there. So it will provide much more continuity of care. And then from 7 to 12 months, we will then try and link them into their local services depending on what the infant's needs are, but again, focusing on the parents' wellbeing and also the baby's development and the parent-child interaction. So that's a study that we've currently got underway. We're getting underway, I should say. We've got our ethics, and we plan on recruiting early next year. And just finally, I wanted to mention a task force related to COVID that I've been involved in, and it's been part of the International Academies of Childhood Disability and the Australasian Academy of Childhood Disability. And this is a multidisciplinary team which includes people from all around the world, and you can see colleagues here from China, Singapore, Africa, America, Canada, England and Turkey, just to name a few. And what we've worked on a number of different things to improve access to children with disabilities over COVID. But one of the really nice things that we did, somewhat crazy, but I'm proud of our efforts, is we put together a 24-hour virtual listening and sharing session. And what we did on World CP Day on the 6th of October is every hour for 24 hours, we conducted these listening sessions and had different hosts from all around the world. So we had, as I said, different people from all these different countries hosting these sessions, and we ended up with over 2,000 people registering. We had 19 sessions, 16 different languages, involved people from 45 different countries and 18 different disciplines. So it was an absolutely fantastic effort to bring people together. So I'll finish there, and as I said, if you've got any questions about our studies, feel free to email me. Thank you.
Great. Thank you so much, Alicia. It's great to see such great collaborative international efforts. So on to our final speaker now. Let's welcome Associate Professor Kathy Sade. Kathy will present on the website that she created during the pandemic. It's called Safe Exercise at Home, and it's all about encouraging older people to stay active. Thanks, Kathy.
As Nat said, I'm going to be talking a little bit about some of the work I've been doing to help keep older people active during COVID-19. We've heard a lot of talk, particularly here in Melbourne, but really around the world, about the various waves of the COVID-19 pandemic. And I suppose my area of interest is in helping older people maintain their function and reduce their risk of falls. So a lot of my work is really in this more chronic phase of health, And so really, I was interested in what was going to be happening in this fourth wave of the COVID-19 pandemic, which is what happens as people neglect, don't receive the normal type of healthcare they would normally receive for chronic health conditions, and they also don't have the same access to rehab that they would normally have. I was also a little bit inspired, but I suppose from personal experience, as we all had these rapid change in what we were doing. I looked around and could see what was happening to older people in my life. So my parents, my mother-in-law, who were all suddenly having to restrict the types of activities they were doing. And I was really concerned about what impact that might have for them. So I became really concerned that COVID-19, the physical distancing restrictions, may actually have some impact on physical activity, both through reductions in normal types of social interactions, but also as people weren't able to participate in their normal leisure activities and exercise options. So things like going to the gym or playing golf or going to exercise classes. And certainly there's some evidence that has come out that certainly has shown that actually there has been a decrease in physical activity in certain groups during the pandemic, and it's probably due to the physical distancing restrictions. Now, for older people, this is quite problematic because we know that reduced physical activity can lead to a reduction in function, and it can also lead to an increased risk of falls and fall-related injuries. So it was, I started having a bit of a look around. There was certainly lots of exercise information out there that you could find on the online or various Zoom classes and things. But again, a lot of this information wasn't always appropriate for older people, and particularly older people who were maybe a little bit more frail or had some level of mobility disability. So the solution we came up with was I brought together a team of leading physios, experts and academics around Australia and clinicians, and we got together and we decided that it was probably a good idea to develop an online resource that was freely available and could be easily accessible from anywhere around the world. So this wasn't a sole endeavour. This had a lot of people, and we came up with the Safe Exercise at Home website. And the purpose of this website was to provide information on physical activity and exercise for older people. And we geared it both towards older people themselves, but also we had a section that was geared towards health professionals, so that people had somewhere where they could go to quickly source information that if they wanted to help advise older people on what sorts of exercises they should be doing. I think it's worth noting we didn't set this up to replace individual physio consultations. It was really to supplement individual consultations, but also for people who maybe didn't know where to start and wanted to get a little bit of background information, or for people that were having trouble accessing individual advice. So some of the key features of the website is that it's evidence-based. So we are really using the most up-to-date information and evidence that we can do to provide the information on the website. We structured it so that it catered for different levels of function. So it has sections that are appropriate for older people who use a walking aid, such as a frame, and maybe are limited to walking around their house, right up to older people that are really very physically active and maybe were going to the gym pre-COVID. We have a very strong emphasis on safety. So making sure, giving people lots of advice about how they can be safe while they're doing exercises. It was designed to be a standalone resource so that really all the information that people may need can all be found on the website. It's freely available to anyone, so people don't have to sign up or pay anything to access the information. Because we knew there was a lot of time pressure to get this out, we did try and use existing resources where these were available, so we didn't reinvent the wheel if we didn't have to. We've also included some downloadable resources so that people who didn't have easy access to the internet or maybe who had difficulty accessing it, someone could download the resources for them and give them to in a hard copy. We included some motivation and success stories because, again, we know that people are more likely to change their behaviour if they can see other people who are like them changing the behaviour and can maybe pick up some tips from them about what worked. We also had consumer input and feedback into the website and all of the resources as we developed them. And we also had the website endorsed by international experts and by professional bodies. I think one of the other really important things we did was that we delivered this in a timely manner. So from the time we had the first meeting of all of the people that were working on the website to the day we launched the website, we did all of this in 35 days, which is a pretty fast turnaround to go from absolutely, just a fuzzy concept to actually a launch of a website. So again, this is just showing you the front page of the website. So you can see we have different sections for older people, health professionals, success stories, and then we have linked to a wide range of resources. And then within the section, each of these sections, we have different drop downs where people can source individual information. And we also have a number of small videos in there, which again just give people some explanation and maybe explain a little bit about why exercising is important and how hard you should exercise, for example. This is an example of the 3 different levels that we have developed the resources for. So we have resources for people at level 1. So again, these are people who are maybe unsteady or are using walking aids and maybe haven't necessarily done much exercise before. And as I said, right up to people who were at more advanced levels, so people who were regularly exercising pre-COVID, but maybe were no longer able to get to the gym and may have been looking for some alternative exercise suggestions. And as you can see, again, we really emphasised that if people had any questions or concerns that they needed to go and speak to a health professional. One of the things we did launch after we initially launched the website was a downloadable brochure. So again, this has all of the information there for people. And these are just a couple of examples of some of the success stories. And again, so you can see we had a variety of people. I think this is Leslie who uses a frame and talks about the types of exercises she's doing, right up to someone who's doing Tai Chi in the park and was very active. So once we launched the website, we promoted it via mainstream media. So we were on the Channel 7 News, which was pretty exciting. We launched it on social media. We advertised it through various professional bodies and also through consumer-focused organisations such as Council of the Ageing and various other methods. And we actually had, again, fantastic interest in the website. So between 5th of May and 22nd of September, we had over 26,000 users, and 15% of those are people that are coming back to look at the website for a second or third occasion. Again, probably not surprisingly, most of the users are female, but also, interestingly, most of the users are over 55. So again, we've had huge numbers of sessions and page views, and we're finding that most people are either being referred the website or are entering the clicking on a link and accessing it directly. Again, the website's been accessed by over 80 countries around the world, mostly here in Australia. But again, you can see we've also had people access it from America, Denmark, the UK and Canada. And so just to finish up again, just to really acknowledge the huge work of the team behind the website to bring this all together. It really was a very collaborative and a very team-based approach to bringing this together. The APA, who again provide us with endorsement, and again they did that in a really very timely manner. The international advisors who again reviewed the website and provided us with feedback, and all the consumer advisors and the success story participants. And that's all from me.
Thanks so much, Kathy. What a fabulous resource. So what we're going to do now, just for the last little bit, is we're going to move into some Q&A. I'd love to thank all of our fantastic presenters for your insightful and really interesting presentations. So I'll get all the speakers to turn their cameras on again. So we've received a number of our questions and we'll do our best to cover as many as we can. So one of them that we've received, a lot of them are for Rana and Kim. So you're up. So considering that telehealth has been considered as a an effective delivery method, have you gathered any cost effectiveness data that could justify telerehab as a permanent way of delivering treatment in the future?
That's a great question, and there's actually not a lot of data here in Australia about cost effectiveness. It's actually a key component of the PEAK trial that we're currently doing. So we are collecting a lot of data there from health service usage, but also looking at costs with respect to time spent travelling. And time not spent travelling, obviously, when you're comparing telehealth to face-to-face. So with respect to that, we will have some quite robust data from that trial in a couple of years. Kim, we've got some data from the surveys about what people paid. Did you want to say anything about that?
Yeah, the costs were probably a little bit lower than what you might do face-to-face, but whether that just reflects people making it a bit cheaper, or physios making it a bit cheaper for patients during the pandemic as they rapidly transfer over. But what we also did find was that, and we surveyed the patients when they'd finished their episode of treatment, and what we found was that the average number of treatments were only sort of 2.9, a mean of 2.9. So it's not like people are overusing them and having more and more than they would normally. And again, that was something that the health insurers are very worried about, that it would be open to abuse and, by telephone and so forth, that it'd be over-servicing. But we didn't really find that in that data.
Great. Okay, I'm going to give two more quick ones to you two and then move on to another couple. So for Kim, was the Metro Rural, was that for a local service, or did you also ask if the rural patients would be happy for services in the city via telehealth?
Yes, we didn't really ask that, but my guess would be that it's actually local services that they've just switched over to deliver it via telehealth, but we didn't specifically ask that.
Okay. And the last one for you guys is, did telehealth consultations, did they perfectly match the usual timings of a physio consultation? I'll leave that. It's a long question, but I'll leave it at that. Was it a good match for timing?
Sure. We didn't ask that in the surveys that Kim has spoken to, so we can't really break down how people spent the different time in their consults. With regard to how we structure it in our research programs, it kind of still vaguely matches the time. However, I would say that there is more time spent on discussion with the patient, so a much greater emphasis on sort of the more traditional subjective assessment with a conversation around patients. And certainly within our PEAK program, we really do emphasise the important role of education. So I think more time and emphasis is spent on that. Perhaps not to say that we shouldn't be doing that in face-to-face, but I think certainly the telehealth and video conferencing really lends itself to that.
Great. I'm going to ask you another really quick one. Just how was patient confidentiality managed whilst using Zoom? Just because you might not be compliant. to the
Yeah, look, I think it depends on the variant of Zoom that you have, and certainly Zoom did lots of security upgrades over the course of the year, but there's lots of different ways that we certainly encourage physios to do that by, for example, using passwords so patients can only access the link via a password, using the waiting room so you can control who can come in and out, and various other features like that, but certainly also thinking about the other things that might happen, not just within the video conferencing, but how you might be sharing information and disseminating emails or recordings, thinking about all of those things, and of course thinking about informed consent and recording that as well.
Great. I'm going to do 2 more questions. Quick one for Alicia. What a great program, especially for rural families. Will you be doing face-to-face training for physios once we're allowed to? I think it'll revolutionise early intervention for babies.
Thanks. Well, we're doing our trial first. So part of doing the randomised controlled trial is it will take us time, and we need to see if it's effective before we then train people. But that's referring to the Teddy Prem trial. In reference to whether we're doing face-to-face training to help with telehealth, I guess we haven't needed to and haven't had the demand yet. We're finding that people are really happy with the course, but it is something that we're starting to plan again, doing some of our face-to-face training when we hope that we can. So we are looking at doing that for some of our courses on early detection of cerebral palsy. Fingers crossed by the end of the year, but we'll see, in very small groups. The other thing I just wanted to add on just quickly in terms of what Rana was saying with timing, we find I'm finding clinically in pediatrics it's really variable depending on how much the families or the kids can tolerate being in front of the camera. But it's been fantastic from my perspective of someone who works in a hospital to see the home environment. So it's really been great doing telehealth to see what's going on at home, and really as a therapist being more of a coach and getting the families more involved rather than having that tendency to take over, which we shouldn't do. But telehealth really makes you sit on your hands and work hard. So I think it's been great in that sense.
Great. And I've got one final question for all the speakers, but are there any nuggets of advice on how to keep the momentum of telehealth use as clinicians up? So how can we keep it up after COVID? Is there anything we can do on the ground as clinicians to keep our innovation going rather than it just being a phase? So anyone can talk to that.
Well, I'll just add, I'll got my microphone on, then I'll mute myself. But I think it's really asking our consumers what they want. And I think a lot of consumers, from my perspective in pediatrics, particularly I work with very young babies, families are really happy not to put their baby in the car and have to travel and worry about sleep time and feeding time. And it's just saving so much time. And I really think consumer voices are just so important. So if they can advocate and tell you whether they like it or not, I think that's a really good place to start.
Great. Does anyone have anything else they want to add to that?
I'll just add something from the clinician side. And I think a really important thing, it's like anything with a new skill or something new that you learn, you only get better with practice. So I think it's really important that we keep developing and using these skills and offering these services. And I think a really important thing for physios is figuring out how to integrate a telehealth service into their more usual traditional face-to-face services as well. Because as Kim presented, certainly there are some clinicians who are practicing entirely via telehealth, but probably what we're going to be seeing going forward is a mix of a blended model. And I think we really need to be able to set up our workflow and our clinics so that we really can offer telehealth in a really integrated, seamless way. So it fits in with appointment bookings, and we've got to sort out payment mechanisms and all of those sorts of things that will really take away those barriers from a clinician perspective. Because as Alicia said, I think our consumers, certainly a big chunk of our consumers, will want it. So we really need to make sure that we can offer that service, that we equally want to offer that service, and it's a worthwhile one.
Can I just add one quick little story as well? We had a really good case on the COVID ward at the Alfred, where it was really well known to the respiratory team, was admitted. And I think as a clinician on the ground, it's really important to advocate. So yes, your patients do really, really like it. Don't be afraid to get on board with the telehealth, because that patient was able to get the right care at the right time in the emergency department and on the COVID ward before they were transferred to the respiratory team. So it was a really good opportunity to provide the best outcome as soon as we can when they come into the acute sector.
Thank you so much. I think we'd better wind up there. So I'd very much like to thank our 5 wonderful speakers for your amazing presentations tonight, and thanks for sharing your successes during the last few months. And I'd love to thank our guests too for joining us tonight. And just a reminder that we will be circulating a recording of this webinar afterwards. So thank you so much, and good night, everyone.